Um, as I said, good afternoon. My name is Jesse Cross-Call. I work for the Office of Intergovernmental and External Affairs here at the Department of Health and Human Services. Really appreciate everybody making the time to join us today to talk about the end of the COVID-19 public health emergency. As you're probably aware, last week on February 9th, Secretary Becerra informed governors that he was going to extend the COVID-19 public health emergency for another 90 days to May 11th. There's a lot of moving pieces involved with this, and so we want to make sure that we are in touch with all of you about what this means for you, your partners, your states, and the people you work with. So today we are joined by folks from the Office of the Secretary, the Centers for Medicare and Medicaid Services, the Substance Abuse and Mental Health Services Administration, and the Administration for Community Living to walk through everything we are doing here at HHS to transition away from this PHE. So before I hand it off to our first speaker, just want to go over a few logistics for you. First of all, this session is being recorded, and we'll be able to send it around later. Second, if you would like to follow along through closed captions, there's a show captions button at the bottom of the screen that you can click on. And then finally, while we do have some really good speakers lined up, we want to make sure that we have time to take your questions. In order to do that, you can use the Q&A function at the bottom of your screen. We're going to hold most questions until the end, but feel free to submit questions at any time through the Q&A button at the bottom of the screen. And so with that, I'm going to welcome our first speaker, Stephen Cha, who is a counselor to Secretary Becerra. Steve?
Thanks so much, Jesse. And again, appreciate all of you making time to join us today. Again, my name is Steve Cha, counselor to the Secretary for COVID here in the Department of Health and Human Services. Just going to give a few introductory comments and give you a bit of a top line before turning it over to some of my colleagues around the department to talk about some of the more specifics within the action that happened. So let me start off with what actually happened. What actually happened on Thursday is that the Secretary sent a letter to the governors advising them as of February 11th, that's Saturday, he's renewing the public health emergency for COVID-19 for 90 days. I want to be clear, this action is based on the most recent COVID-19 trends. He also advised the governors that he intends for this to be the final renewal of this PHE, meaning that this renewal would expire on May 11th, 2023. That's 90 days after that February 11th date. This is consistent with the administration statement back on January 30th that we planned for the public health emergency to end on May 11th. I want to be clear, in the past, we have committed to the governors that we would give 60 days notice. Because we want to do all we can to ensure a smooth transition, we gave 90 days notice instead. We also sent the governors a roadmap, which is now publicly available. And that roadmap summarizes what's changed and, really important, what has not changed. I'm going to let some of my colleagues get into some of the details, but I want to hit on a few top lines in that document. First of all, this nation is in a better place in our response than we have been. Over the last 2 years, this administration has implemented the largest adult vaccination program in US history. Nearly 270 million Americans have received at least one shot of the COVID-19 vaccine. And since the peak of the Omicron surge at the end of January 2022, daily COVID-19 cases are down by 92%, COVID-19 deaths have declined by over 80%, and new COVID-19 hospitalizations are down nearly 80%. We have gotten here because of our historic investments and our efforts to mitigate its worst impacts, and perhaps most critically, our partnerships with people like many of you on this call right now. Second, I want to be clear, we are not done. Addressing COVID-19 remains a significant public health priority for this administration, and we know so many people are still affected by COVID-19 each and every day. And so in order to ensure an orderly transition, we have been working for months and will continue to work for months so that we can continue to meet the needs of those affected by COVID-19. That means that you will all be hearing more from us, and we will continue to issue materials and have more conversation over the coming days and months about the impact of this particular transition as a COVID-19 PHE expires. The roadmap also hits on what changes again and whatnot. I'm not going to repeat all the various points in that document, but I want to hit on a couple top lines, particularly ones that my colleagues aren't going to cover. The one point that's come up time and time again, and so I want to be crystal clear about this, access to COVID-19 vaccinations and treatments will generally not be affected. I think Dr. Jha, the COVID-19 task force coordinator, tweeted out recently today, and on May 11th, Americans have access to COVID-19 vaccines and treatments in pharmacies and in places around all Americans. And on May 12th, if the PHE concludes, that's going to continue. Separate from this public health emergency, because we have to ensure a smooth transition for the provision of COVID-19 vaccines and treatments, we are working to ensure a smooth transition to move to the traditional healthcare marketplace. That is not happening at the same time as the end of the COVID PHE. In that tweet that Dr. Jha tweeted, he also tweeted out that that process expected to take place in late summer or early fall. So I want to say that again. If we plan for the PHE to expire on May 11th, on May 12th, Americans will continue to have access to COVID-19 vaccines and treatments for free, just as today. We will be beginning to make that process of transitioning to the commercial marketplace in late summer, early fall. For that second process of transitioning to the healthcare marketplace, again, late summer, early fall, we've already been working for months with partners, with multiple webinars and conversations. Many of you have probably joined them, and we're committing to executing that transition to the traditional healthcare marketplace in a thoughtful, well-coordinated manner. We've done a lot of stakeholder engagement and will continue to do so, and we still have work to do. So I want to repeat, this transition to more traditional health coverage is not tied to this May 11th expiration of the COVID-19 PHE. We will all still have access to free vaccines and therapeutics on May 12th. And as we head towards that late summer or early fall, we will continue to work with stakeholders to ensure a smooth transition, particularly taking care to think about the needs of uninsured, underinsured, and people like seniors and people with disabilities who need those products the most. Before I turn it over to my colleagues, just 2 points because some of my colleagues from FDA and CDC aren't on this call. So I just want to hit 2 points in that roadmap that have come up in questions since that time. One is that FDA's emergency use authorization for COVID-19 products, so that's how many tests, vaccines, and treatments are on the market under emergency use authorization. It's not going to be affected. And FDA released information about this publicly right after that January 30th announcement. So that means that FDA will continue to have authorization over the various products. Existing emergency use authorizations will remain in effect under Section 564 of the Federal Food and Drug Cosmetic Act. And the agency may issue new EUAs, emergency use authorizations going forward when criteria for issuance are met. The second piece relates to CDC. Again, a lot of questions have come in for this. This is one of the things that will change. That FDA piece is, again, something that won't change. One thing that will change is the reporting of COVID-19 lab results and immunization data will change. During the PHE, HHS has had the authority to require many types of reporting for COVID-19. And at the end of the COVID-19 PHE, some of this, not all of this, but some of this will change. Just as, for instance, HHS will no longer have the express authority to require lab test reporting, which may affect the reporting of particularly negative test results, and may be harder to calculate, for instance, percent positivity for COVID-19 tests in some jurisdictions. Many labs will continue to report voluntarily, and we continue to encourage that. And if that happens, the states will report that onto the feds. We will have that data, but we won't be able to require that. The second thing is that vaccine administration data will also no longer be required, but I want to be clear. CDC has been working to sign voluntary data use agreements, encouraging states and jurisdictions to continue sharing this critical vaccine administration data. And the majority of jurisdictions and states and jurisdictions have indeed signed one of those DUAs with us. And then finally, this goes into the CMS space, and so Jean may pick this up as well, but hospital data reporting, which also comes under this data reporting bucket, will continue as required under the CMS conditions of participation through April 30th, 2024, but the reporting may be reduced from the current daily reporting to a lesser frequency. those are the specifics I wanted to hit, but let me end my portion by just underscoring a point I made up top, which is that we committed to 60 days notice and we gave 90 days notice because we know that we want to work with so many of you. And that separate process of transitioning to standard coverage, we have until late summer or early fall. The point is, and the point of this call today, is we have time to work with our partners, to listen to concerns and to address concerns. We're going to use that time to provide guidance, provide information, and more importantly, listen to feedback. And this additional time allows us to work with all of you and all affected parties to ensure a smooth transition. Let me turn it back to Jesse at this time.
Wonderful. Thanks, Steve. And like we said, we are going to hold questions to the end, but we did get a number of folks who asked if they could see the roadmap that Steve mentioned a few times. We've put that in the chat for this. We also included it in the invitation that got sent out last week, and we will include it in follow-up information that we send along as well. So with that, I'm going to hand it off to Jean Moody-Williams, who's the Deputy Director at the Center for Clinical Standards and Quality at CMS. Jean?
Thanks so much, Jesse, and thanks to all of you for all that you've done throughout this period of the PHE. I'm going to speak to the general disposition of the CMS Medicare flexibilities at the end of the PHE, and Hannah Catch will follow me with more specifics on Medicaid. Now, when I use the word flexibilities, I'm referring to waivers, guidances, such as our quality, safety, and oversight memos that go out to state agencies, and our emergency interim regulations. Now, since March of 2020, CMS has issued hundreds of flexibilities, and in general, they were issued in response to the PHE and are appropriate only as emergency measures. And thus, while COVID remains a priority, we are in a better position to end the PHE and transition away from an emergency phase and thus in the emergency flexibilities. The regulations that were in place were there to continue to ensure health and safety, and we want to make sure that we continue that commitment. A few CMS flexibilities will continue for a period after the end of the PHE, and I'll touch on those in just a minute. But first, I want to make sure that you are aware of where to get information that will be very helpful to you as we continue to approach the May 11th date. We actually began preparing for the end of the PHE a while ago and have provided ongoing information regarding the flexibilities that will end or have already been terminated or will be made permanent. And you can find this information on our website at HHS.gov. Once you get there, you can click on Coronavirus Disease 2019, and you'll be taken to the emergency page. In August of last year, we developed a CMS roadmap. We talked about one roadmap today, but we've also have a CMS roadmap for all of the flexibilities that were issued. And we have several fact sheets specific to various settings and that was in preparation for the end of the PHE. And we've continued to encourage providers to discontinue the use of the waiver when they're no longer needed. And even before the date of May 11th, if you want to start a gradual adjustment of the process. As mentioned, depending on the authority, a few flexibilities will continue for a period after the PHE. For example, the Consolidated Appropriations Act of 2023 extended certain telehealth provisions until December of 2024. The act also provided for an extension to the Acute Hospital at Home initiative, which was extended through December 31st of 2024. So hospitals can continue to apply to participate in the initiative if they meet the requirements as spelled out in the act. The CMS reporting requirements, as was just alluded to by Stephen, those reporting requirements for hospitals and critical access hospitals are caused to report data to the CDC's COVID-19 module of its National Healthcare Safety Network. That will continue until April 30th of 2024, but reporting may be reduced from the current elements or the daily reporting to a lesser frequency, and we will continue to keep you updated on any changes in those requirements. For those that have Medicare access to COVID-19 vaccines, testing and treatment at no cost will continue through September 30th of 2024. And following this date, we will cover ACIP recommended vaccines for most beneficiaries thereafter. Access to medically necessary laboratory-based COVID-19 PCR and antigen tests will also continue without cost sharing for our Medicare beneficiaries when the test is ordered by a physician or other clinicians. However, the program that currently provides people with eligible for Medicare with free over-the-counter testing, that will end with the PHE. Now, one of the areas we get frequently questioned about is related to scope of practice for advanced practice clinicians or other physicians. In most instances, we defer to state law regarding licensing and scope of practice. Under Medicare Part B, however, there are certain types of services required to be furnished under direct supervision by a physician or practitioner, and CMS temporarily changed the definition of direct supervision to allow the supervising professional to be immediately available virtually. This flexibility will expire at the end of the calendar year in which the PHE ends, in this case, 2023. Now, while the flexibilities may end, please know that we routinely review our regulations, even in the absence of an emergency, and we will continue to review this as well. One last area that may require attention in a state or a county jurisdiction in particular is the training of nursing aides in the nursing home. We initially provided discretion related to the time to complete the training so we could get more people into the workforce. That discretion will end with the end of the PHE. And at the end of the PHE, nurse aides will have 4 months after the end to complete the required certification training. Now, we understand that there is or was a backlog in state training programs. So we encourage all states to consider how it will accommodate this training need as the PHE comes to an end. Now, we have had stakeholder meetings, technical assistance, and resources all throughout the PHE. That won't stop. We will continue to work with you. Again, I thank you for all that you have done, and we are always available to provide any information necessary to ensure that we're providing the best care and services in the best manner possible for those Medicare beneficiaries. And with that, I'm going to turn to Hannah to talk a little bit about Medicaid.
Thank you very much, Jean. I'm going to talk, my name is Hannah Catch. Thank you for being here. I'm a senior advisor in the Office of the Administrator at CMS. I'm going to talk a little bit about the Medicaid flexibilities under COVID-19, including those that were established as part of the PHE but have ended unrelated to the PHE. So in 2020, Congress passed the Families First Coronavirus Response Act. One of the provisions of that law included enhanced federal funding for state Medicaid programs with a condition that in order to receive those funds, states must keep people enrolled until the end of the public health emergency, regardless of whether those individuals' circumstances changed. During the pandemic, Medicaid has really served its core purpose of providing reliable health coverage to more than 90 million individuals and families in unprecedented circumstances. And in December of 2022, Congress created an end date for this continuous enrollment provision that is not connected to the public health emergency. Because of this new law, states are now returning to regular operations over the next several months. And some people who are no longer eligible for Medicaid coverage may lose that coverage as early as April. CMS has been working in partnership with state Medicaid agencies over the last year in preparation for the end of the COVID-19 public health emergency and to ensure a smooth transition back to regular Medicaid operations. Our goal is for people who continue to be eligible for Medicaid to keep that coverage, and for those who are no longer eligible for Medicaid to transition to another form of affordable coverage, such as through the health insurance marketplaces. For people whose incomes make them ineligible for Medicaid, many will be eligible for no cost or low cost coverage on the marketplace. The most important takeaway is that right now, everyone with Medicaid coverage whose contact information has changed during the last 3 years must confirm that they have updated their contact information with their state Medicaid agency so that they can receive the notices regarding their coverage as they arrive. For those of you who work with community-based organizations, we hope that you will spread the word that anyone who has moved during the last 3 years should confirm that their contact information has been updated with their state Medicaid agency and their health plan. And anyone who does receive a notice must respond quickly to ensure that they can maintain their coverage. In addition, during the pandemic, states have used many other flexibilities to ensure access to care to support their rapid response efforts to provide healthcare to their enrollees, such as flexibilities related to how and where enrollees can receive care. Many of these flexibilities will be available for states after the PHE ends, if the state chooses to continue them. So for example, in telehealth, in Medicaid, the flexibility to offer telehealth services was available prior to the public health emergency and will continue to be available to states after the PHE ends. And we encourage states to continue to utilize telehealth for delivering services to Medicaid enrollees, should they choose. In addition, under the law, Medicaid will continue to cover COVID-19 testing, vaccines, and treatments at no cost to individuals through September 30th of 2024. After that, Medicaid will continue to cover these items to the extent permitted under federal and state law. I want to make sure that we have time for questions at the end, so I will leave it there, but I'll just note that our CMS team is working closely with every state and many other partners across the country to ensure that the Medicaid unwinding process goes as smoothly as possible. And we are so grateful to the partnership of so many of you to maintain coverage for every eligible enrollee. So please feel free to reach out to us if we can answer any additional questions. Jesse, back to you.
Great. Thank you, Hannah. Thank you, Jean. So one question that we've got a few times in the chat is just if this session is being recorded for those folks who have joined late or were unable to join today. And the answer is yes. It is being recorded and we will distribute it after the session today. So next, I would like to bring on Dr. Ingvild Olsen, the director of the Center for Substance Abuse Treatment at SAMHSA. Dr. Olsen.
Great, thank you so much, Jesse, and good afternoon, everyone. Thank you so much for being here, and thank you for all the interest. I know that this is lots of questions about how this will go. From SAMHSA's perspective, there are two COVID PHE related flexibilities that I wanted to highlight that we wanted to just make sure everyone knew about. So the first is that the public health emergency permitted a waiver of the criteria for determining the provision of methadone take-home doses for people who are receiving treatment for opiate use disorder in opioid treatment programs. And that flexibility really allowed stable patients to receive up to 28 days of methadone take-home doses, while unstable patients who were otherwise determined by the OTP medical director to be able to safely handle those take-home doses could receive up to 14 days of methadone without having to meet the time and treatment criteria that is defined in the 42 CFR Part 8, that is the regulation that SAMHSA has jurisdiction over that governs opioid treatment program standards. Now, over the past 2 years, studies and qualitative data from providers, patients, and advocates have identified that this flexibility has helped people remain in treatment longer, return to work and school, and really otherwise engaged in recovery-oriented activities without an increase in methadone-related harms, including overdose. And so as a result, SAMHSA has incorporated this flexibility into its proposed changes to the Part 8 regulations that are currently out for public comment. That comment period actually closes tomorrow. But to allow time for the regulatory process to be completed, SAMHSA issued guidance in November of 2021 that extends the blanket methadone take-home exception for 1 year past the end of the COVID public health emergency. And so that is until May 11th of 2024. We do anticipate finalizing the Part 8 revisions prior to that, however. So the second area also involves treatment of opiate use disorder in opioid treatment programs. So under the COVID PHE, SAMHSA allowed for the initiation of buprenorphine in OTPs via telehealth, including audio only, without an initial in-person physical examination as required by Part 8. So this also is a flexibility that we have proposed making permanent as part of the Part 8 rule changes. So I know that there was a question in the chat or in the Q&A about what happens with respect to buprenorphine that is prescribed via telehealth outside of OTPs. That is within the lane of the DEA, and SAMHSA and the DEA have been working very closely to make sure that there is continued access. But I am not able to speak directly to the DEA regulations as that is really within their lane. So with that, I will turn it back to you, Jesse.
Thank you, Dr. Olson. So for our final speaker, I want to bring in Jeff Hild, who's the Principal Deputy Assistant Secretary at the Administration for Community Living. Jeff?
Hi, thanks, Jesse. Jeff Hild here from the Administration for Children and Families. For ACF, we have two categories of programs that are relevant here. First are programs impacted by the federal medical assistance percentage, or FMAP, enhancement of 6.2% that was put in place in early 2020 as part of the Families First bill that Hannah mentioned earlier. And second are our Head Start and tribal child support programs, which have provided certain administrative flexibilities tied to the public health emergency. So in that first category are our Title IV-E child welfare programs. So this is foster care and guardianship and adoption assistance payments, as well as programs under the Child Care and Development Fund. For each of these, the FMAP is used in determining federal and state contributions. In the case of our Title IV-E child welfare programs, the enhanced FMAP has meant that the federal government has picked up a larger percentage of foster care and adoption assistance and guardianship payments. As a reminder, the kind of baseline FMAP here ranges from 50% to around 78%, depending on the state. For childcare, the enhanced FMAP meant that states had a decreased cost share amount required to claim their full allotment under the Child Care Development Fund formula. Congress has already stepped in to unwind the FMAP enhancements through the FY23 appropriations bill that passed at the end of the year. That bill created a gradual phase out over the course of calendar year 23. With that enhancement, the increased FMAP dropping from 6.2% to 5% on March 31st, down to 2.5% on June 30th, 1.5% on September 30th, before finally phasing out completely on December 31st. So because of that congressional action, this phase out is occurring regardless of the PHE unwinding. Our second category are our Head Start and tribal child support programs, which have provided certain administrative flexibilities under the PHE, and those will be unwinding upon termination of the public health emergency. For Head Start, those flexibilities included removal of prior approval for some purchases, procurements, and budget modifications, an extension of some reporting requirements, along with other flexibilities. So our Office of Head Start has issued updated guidance to our grantees throughout the public health emergency, including recent guidance around what the unwinding will mean for grantees going forward. For tribal child support agencies have been provided flexibility in requirements for seeking an emergency waiver of their non-federal share. And upon termination of the PHE, the existing requirements for cost share waivers, including documentation related to claiming those waivers, will go back into effect. And our Office of Child Support Enforcement has issued updated guidance to our tribal agencies, and will continue to work closely with them. Jesse, that is it for me, so back to you.
Thank you, Jeff. All right, so those are the speakers that we had lined up today. Now we are going to transition to the Q&A section. So if the speakers could come back on video. And so this is a time, if you haven't already, to put your questions into the chat. We have a lot coming in, not sure if we'll be able to get to all of them, but we'll try to make some headway on them. So the first question I'll actually pose to Jean. And the question is, will long-term care facilities still be required to routinely test all staff for COVID-19 on a certain frequency? And if you still have to report COVID-19 cases in nursing homes?
So thanks. And I was watching the Q's and A's as we were talking. There are a lot of questions in there about long-term care facilities and nursing homes. So let me just say that we will be also having a special stakeholder call, as we have done all throughout the PHE for long-term care facilities. And we thank you for these questions, because that will help us prepare for that stakeholder call for some of the specificity that you're looking for. I will say that as it goes for requirements for long-term care facilities to test the faculty and staff, that will expire with the conclusion of the PHE or the sunset of the rule, which is whichever comes first. So the PHE in will come first. The rule sunsets in September of 2023, I believe. But as far as the reporting requirement for long-term care facilities to report nursing home resident and staff infections, potential infections, deaths related to COVID, that will not expire. We actually finalized that in the home health rule in 2022. Reporting of COVID vaccine status of residents and staff does not expire. So there are certain nuances of what will still be required and not. So we will make sure that you have that information. It is, a lot of that is already available as we have been sunsetting a lot of the guidance, as most of our work has been through guidance for long-term care facilities all along. Thank you.
Thanks, Jean. And I'm going to keep it here with you and Hannah, and specifically around telemedicine. And I know you both covered this in your remarks, but if you could, I think, reiterate and just say a little bit more about the fate of telemedicine after the PHE ends.
I'll start and then go to Hannah. So the Consolidated Appropriations Act extended many of the telehealth flexibilities through December 31st of 2024. So for those who have Medicare, they can access telehealth and telecommunication services in any geographic area, rather than only prior to that in areas, rural areas, in many cases. So the beneficiary can stay in their home for telehealth visits that Medicare pays for. And they can be delivered, certain can be delivered via telephone. And I know that that's also a concern. For Medicare Advantage plans may offer additional telehealth benefits. The beneficiary will have to check with the Medicare Advantage plan to see how that will work. And we will continue to put out information, but as you can see, that is not going to be an immediate stop to most of telehealth benefits. And Hannah?
Thanks, Jean. On the Medicaid side, many states adopted new telehealth flexibilities during the COVID-19 pandemic, but in fact, that the authority to offer those flexibilities actually existed prior to the pandemic and are unrelated to the end of the PHE. So in most cases, states can choose to continue those flexibilities, and it is up to the state whether they choose to do so.
Thank you. All right, so I'm staying with Hannah, but also Steve for this one. Access to free vaccines and treatment for COVID. What is the fate of that post PHE?
On the Medicaid side, states are required to cover testing, vaccines, and treatments for Medicaid enrollees through the September 30th of 2024. After that point, many of those services and products will continue to be covered, but we will return to regular Medicaid rules. So coverage will depend on the factors that determine coverage outside of a public health emergency. But in general, those services will still be covered.
And let me step back to give a slightly broader lens of what's happening on this front of the free vaccines and tests and treatments that have been available over the course of the pandemic. And again, I think we still will be distributing free vaccines and free treatments on May 11th and still be doing it on May 12th. So, and that will continue, as I said, until this process of at some point in late summer, early fall, we will be transitioning coverage for those back to traditional coverage. But as Hannah just mentioned, a lot of programs like Medicaid have already changed some of their frameworks and thinking about what it means to cover vaccines and treatment. So even when that transition comes, it's not just going back to a world where we didn't have COVID vaccines. There are other policies in place, even under the insurers, that we're transitioning back towards. And we're leaving that time, early summer, late summer, early fall, in order to have multiple conversations, whether it's Medicaid, whether it's Medicare, whether it's private insurance, to really understand and think through what does that transition look like, and make sure all of our partners, whether it's manufacturers, distributors, or insurers that are going to have to start covering these products after that transition, have adequate time to adjust and ensure that there's no gap in treatment or coverage for people. We do have to also think about solutions and strategies for the uninsured, and we will be disclosing more about that and thinking more about that between now and late summer. So again, I think this question keeps coming up, and the provision of these tests and treatments and vaccines will continue even after the conclusion of the May 11th PHE conclusion, but we do face transition sometime later this year.
So Steve, going to keep it with you on this one. Can you confirm if access to COVID therapeutics and vaccines transitioning to the private market is reliant on the existing supply of federally purchased vaccines?
I think it's a number of factors. I think certainly the usage patterns will change that a lot. Obviously, it's not just our supply, but how quickly these are being used. So all of that is dynamic. If we have, and I think we're seeing, I think part of the reason we're able to project now, and only now that you heard from Dr. Jha, we're thinking about late summer, early fall, is because I think we are seeing sort of the beginning to have an understanding of what this winter surge shape looks like. And as we're seeing more and more and having more confidence that we might be on the far end of that surge or closer to that, it's what's triggering some of these actions, like the May 11th declaration, and like the declaration that Dr. Jha said about late summer, early fall. So part of that is the trajectory of the disease. Part of that is our own supply. Part of this is manufacturers' readiness to begin to distribute that vaccine, and third-party distributors, and making sure that whole infrastructure is in place before we click go on it. That's why that's going to be even more than 90 days. That's why we have months to plan for that time frame that I talked about, late summer, early fall. A lot of different private entities need to begin to set up processes to determine how that looks like. I think our current expectation is that FDA has said in the most recent advisory committee meeting that they expect this fall, most likely, there to be another strain change of the vaccine. No one was committing to that. There was no vote on that. That was the expectation by many experts after that meeting. If that new vaccine this fall is a different vaccine because it's a new strain, it's a different kind of varietal, it would make very much sense for the federal government to continue distributing vaccines and then begin with the new strain through the traditional coverage and distribution practices that we have done historically. That's our current thinking right now in terms of the rough plan. All of this is subject to change, and all of this is why we have left plenty of time towards that late summer, early fall to continue these conversations and watch how the system and the pandemic and the trends are going.
Thanks, Steve. And I'm going to throw one more question your way. And the question is, will the CDC community levels by county check still be available once the PHE ends?
Yeah, I think this is a great example, Jesse, of, again, some things are changing, some things are not going to change, right? So I talked about some potential changes in CDC data, including lab data, and including some of the vaccination administration data. Some of that will go to more of a voluntary framework between the labs and the states and the federal government. I do expect a lot of that data to continue. Again, I want to be very clear about that. Even when I say a change, I expect a lot of that data to continue. Other aspects of the data are not going to change. So for instance, the CDC community levels is determined based on data streams that we do not expect to change. That's based on number of COVID admissions to hospitals. It's based on number of COVID positive tests. And those are both still going to be reported. Again, the loss of the lab reporting means we won't see the negative tests, but we still are going to see the COVID positive tests. And so when we think about the community levels, that's based on two other pieces of data that we will continue to have, we will continue to be able to determine the community levels. And just to remind those of you, the community level is CDC's framework that has the low, medium, and high, whether the COVID levels of COVID in your community are low, medium, and high. And that translates to recommendations like masking, like social distancing, and some of those other pieces. That's all in that CDC website for you all to look at. I think it is our current, and for the time being, our future in terms of guidance, in terms of how we think about mitigation strategies responsive to the level of COVID in our communities.
Great, thank you, Steve. All right, Hannah, this question is for you. What will be done to provide access to testing, vaccinations, treatment for the uninsured low-income patients who are not eligible for Medicaid?
That's a great question. So some states have taken advantage of a coverage group that Congress created in 2020, which allowed them to provide testing, vaccines, and treatments for people who were ineligible for other forms of coverage, including Medicaid. Unfortunately, Congress did not extend the authority for that group past the end of the PHE. So states do not have the authority to cover that group under Medicaid beyond the end of the PHE based on the authority of that coverage group. Some states do have the authority to expand Medicaid in other ways. And certainly we would encourage them to fully expand Medicaid to the extent allowable under federal law.
Very good, thank you. So we're actually running out of time. So we'll just say a few words in closing. First of all, just thank you everyone to joining us today. Thank you to our presenters for speaking with us. We have recorded this session and we will distribute it afterward. Earlier, we put the roadmap that Steve mentioned in the chat, but we will re-up that in the follow-up materials. And also, as more materials and as the need for future calls come around, we will certainly try our best to do that. So again, thank you to the speakers. Thank you to everybody else who joined us today. Have a great week, everybody.